my tribute and deep respect to late Dr. Anita Borges, who started this and who's been a very inspirational figure. We miss her at every step, and we hope to continue these sessions for the many, many more years to come. All right. So if you basically, bone marrow aspiration and refine, these are kind of very old techniques. The pictures that are there on the screen refer to the medieval as well as in the Chinese history, where it was a bone marrow trepanning that was used to drill a hole in mainly the skull for medicinal purposes, to drain out the CSF for treatment of mental illnesses, treatment of headache. This process came for diagnostic utility sometime in the early part of last century, where first time it was reported in Europe by an Italian physician, where bone marrow biopsy was done for diagnosis of leishmaniasis. The first reports of the technique of sternal puncture for bone marrow aspiration came from the Russian literature, where you'll notice, interestingly, lumbar puncture needles were used for this. Okay, so the history is pretty old, and we will now go into this. Now, in the talk today, 5 of you, there'll be a little bit of questioning and all that goes on, and we will learn the basic normal and the approach. In the month of July, Dr. Jasmeeta Das from Delhi had taken a session on bone marrow, so a lot of it will be a repeat, and then we will take up case discussions. It is one of the largest organs of the body, total body weight about 5%. As you know, there are 2 types of cells, hematopoietic and stromal, and 2 main techniques, trephine and aspiration. Okay, now this is a little quiz for all of you. This shows on the x-axis the age in years, fetus as well as the adult, and this is the site for hematopoiesis. So could Ayon tell me, what does the blue mark denote? At which part of the body or which site does hematopoiesis take place in very early fetal life? Anyone? Okay, right. I can hear on the chat. Ayon, are you there?
The yolk sac?
Yes, that's the yolk sac. Sir. Beautiful. That's the yolk sac. Followed by the liver and the spleen. Right. Now, during the mid-fetal till end of, we have the liver and the spleen that take over. The important point of this is, even in adult life, even after we are born, there are foci of hematopoiesis, or the capacity to have hematopoiesis in the liver and the spleen, and extramedullary hematopoiesis, if it's triggered, occurs. That's the reason why we get hepatosplenomegaly in situations of extramedullary hematopoiesis. Thereafter, the marrow starts. Request people to please mute themselves. Those who are not participating, there's a constant disturbance going on. Thereafter, the bone marrow takes place. So when we are born, we have the entire skeleton where marrow is. This is the red marrow. An entire skeleton is involved with hematopoiesis. The important aspect of this, again, translating it, is that in infancy, up to the age of 1, the tibial tuberosity is a site for bone marrow aspiration or biopsy, because the rest of the bones, cartilaginous development is taking place. If you put in a needle, you're likely to get off cartilaginous tissue. So the tibial tuberosity, accessible site for bone marrows in infants only, in up to the age of 1. After which, we generally use the posterior superior iliac spine, and this is the where marrow is remaining in the adult. So it's in the flat bones and in the axial skeleton, as well as the upper end of the humerus and in the femur. So that's where the marrow is restricted to, and that is where pelvis is one of the important sites for doing a bone marrow. Right. Before we start the process of bone marrow, we must know why we do a bone marrow. So the next question that is coming up for all of you is, what are the indications of studying a bone marrow? So one by one, can you just tell me?
So red cell disorders?
Red cell disorder. Could you specify, please? What type of red cell disorders?
Megaloblastic anemia, pure red cell aplasia.
One sec. If in a megaloblastic anemia, do we do a bone marrow? Why do you need a bone marrow in megaloblastic anemia? Who said megaloblastic anemia?
Me, sir.
Hello?
Me, sir. I said, sir.
I need to know your name. I don't get your...
Sir, Sakshi, Dr. Sakshi, sir.
Sakshi, okay. So you said megaloblastic anemia. Can you just explain? Just all of you listening to me, just understand what do we understand by an indication. If it is the case of a megaloblastic anemia, I would not want to do a marrow because I know the diagnosis. So what is my indication to do a marrow? You should say suspected macrocytic or suspected megaloblastic anemia.
Okay, sir.
That apart, remember, that apart in the current age, we have other ways of diagnosing megaloblastic anemia. Okay, like B12 and folate levels are easily accessible. When I was a student about 30 years ago, 40 years ago, then it was a good indication because we did not have access to B12 folate levels. Now it is available, or even if you don't have access, you could give an empirical. So it is suspected. The word is suspected. Some of you have said refractory. Yes. So red cell disorders which are unexplained. Unexplained anemia is an indication of bone marrow. Okay. Any other indication?
Sir, pancytopenia.
Good. Pancytopenia. Again, unexplained pancytopenia. A patient has dengue fever, some amount of pancytopenia. I wouldn't want to do a marrow, right? When my pancytopenia is more sustained, unexplained, right? Good. Any other?
So unexplained fever of unknown origin.
Just, I couldn't hear. Okay, Vishnu says storage disorders. Good. Anyone else?
Leukemias.
Okay. Again, unexplained hepatosplenomegaly, unexplained organomegaly, unexplained lymphadenopathy, or the patient has a lymphadenopathy, right? Okay, that's another. Anything else?
Leukemias.
I'm going to collate all of this. Don't worry. Yeah, go ahead.
Leukemia, sir.
Leukemias.
Again, leukemia means suspected, or you're finding blasts in the peripheral smear, right? I would like to do a bone marrow. Anything else?
Unexplained thrombocytopenia.
Unexplained?
Thrombocytopenia or thrombocytosis.
Okay, unexplained thrombocytopenia. Again, someone said ITP. I will contradict that in a little while. We'll discuss all of this. Okay, so basically we've come across with a few findings that are important, let's say. So the word is investigation of unexplained anemia or abnormal red cell indices, unexplained cytopenias, unexplained cytosis. Understand? Any of these disorders which is unexplained. So your pancytopenia, macrocytic anemia will come in that. Or there is unexplained cytosis. Most of your leukemias can fit into that. Okay, that's one. Second, investigation of an abnormal peripheral blood morphology suggesting of a bone marrow pathology. Can anyone tell us what are these abnormal bone marrow, peripheral blood abnormalities, which will make you do a marrow?
MDS.
So what is the abnormal morphology?
Sir, it can be in terms of, sir, erythropoiesis or granulopoiesis, or in terms of
can you specify? Can you specify? Don't talk. I would request all of you to be more specific with examples. Yes, very good, Jivanita. You have said it is Jivantika. Presence of blasts. That's an abnormal peripheral blood morphology. Anything else? Teardrop cells. Leukoerythroblastic blood picture. That's a peripheral blood abnormality, right? Morphological abnormality. That will make me think, okay, this patient probably has anemia, and once these changes are there, I'd like to do a bone marrow. Right? Good. Next. The entire lot of hematological disorders. We do it for diagnosis, staging, and follow-up of malignant hematological disorders, right? All of these, acute, chronic leukemias, MDS, myeloproliferative plasma cells. So when you're suspecting it, and once diagnosed, for staging purposes, for knowing the extent of the disease, and follow-up. Okay, right? Agreed, all of you?
Yes.
If you also, the 5 of you there, if you have any questions at any point, stop and let me know. Or you put it in the chat box and we'll periodically go through the question answers, right? I don't want doubts left in your mind for a long time. So shall I move? Next indication. When you are suspecting bone marrow mets, again, there's an overlap. Previous one, morphological, or there are certain unexplained focal bony lesions, lytic lesions in the X-ray, somewhere in the bone, not being able to solve out why there is lytic lesion. Is it myeloma? Is it metastasis? I would like to do a bone marrow. This is again unexplained organomegaly or presence of mass lesions, a mediastinal lymph node. Very difficult. You're not getting good access to that mass, either as a fine needle or in a true cut biopsy. Deep-seated retroperitoneal lymph nodes. Okay, I would again, because it's inaccessible, I'm suspecting a hematological disorder. Let's look at the marrow, right? When your investigation, someone did mention all your investigations of storage disorders. Again, someone might say that currently we have enzyme assays for storage disorder, but that apart, morphology is important when you're suspecting storage disorders. Okay. PUO. Some of you did mention PUO. Again, unexplained. Or when you are suspecting some specific infections where marrow is involved, especially Kala-Azar, Leishmaniasis, chronic malaria, miliary tuberculosis. Both these situations, a marrow. And most of these time for PUO, we do a marrow for culture studies. But as a byproduct, the aspiration of the biopsy can be done and observed. But culture comes primarily. Currently, we also do a lot of marrows for stem cell donors. To exclude any possible hematological disease in them, marrows may be done. Similarly, prior to elective splenectomy, to see for normalcy of the marrow, you can do a bone marrow. So these are some of the indications for bone marrow examination, right? I'm sure there will be some that will come up in the course or some that you can think about. So there is no strict definition as to what are the indications. There are never ever a situation where you have only 5 indications. You can build up your indications case by case. All right, but generally speaking, these are some of the indications for doing a bone marrow, right? Okay. So now let's come to the procedure. This will go fast because I'm sure all of you, just a little idea that I need. How many of you are doing bone marrow aspirations? Just give me a raise of hand or say that. Are you all, most of you in the audience, reporting bone marrow aspirations?
Yes.
Yes or no?
Yes.
Yes, great. Trephine biopsies? Trephine biopsies now? Yes or no? On a routine basis?
Yes.
On a routine basis, trephine biopsies? Okay. Okay, fine. So basically, we see that we are doing, you are familiar with the process. So now tell me the sites quickly. Sakshi?
PSI is a posterior superior iliac
Yeah.
spine.
That's the commonest site. Very good.
Commonest.
Posterior superior iliac spine is the commonest site for doing the bone marrow trephine. Any idea why? Why not any other bone? Of course, if you understand that in an adult where all bone is there, pelvis is accessible. And if you were to study literature says this is the best representative of the bone. The pelvic bone marrow is the best representative of marrow in the whole body. Okay. Other possibilities, anterior superior iliac spine. I have done it once or twice. Difficult to do. Iliac crest as such, yes. Tibial tuberosities in infants. Now, one thing that whenever we are doing a posterior superior iliac spine, it's important. Well, let me see if I can get the pointer. Yeah. Whenever we are doing a posterior superior iliac spine, the patient is best kept in the fetal position, or left lateral or the right lateral position, rather than being supine. And the needle, it's important that you direct the needle towards the umbilicus. Don't go perpendicular. Angle it in such a way that the needle tip faces the umbilicus of the patient. Then you know that you are inside the marrow, inside the bone. And you will go across the bone into the marrow. If you alter your angle, you're likely to go along the crest. And then what happens is you'll either get cartilage or only bone. So you need to angle your marrow towards the umbilicus, provided your patient is in this position, so that you can cut across the bone and get into the marrow. So that's important. Okay. Any other site that was commonly used earlier?
Sternum, sir.
Sternum. What is your take on the sternal cultures? How many of you do it now? It's hardly ever done. Okay, because Current practice is to do the aspiration and biopsy simultaneously, and therefore sternum is a strict no as far as a trephine biopsy is concerned, because you're likely to overpenetrate and cause great damage to the patient. If by chance you're doing a sternal puncture, it's only for an aspirate, and you will have to use the Sala's needle, the aspiration needle, which has a guard. Keep your guard maximum at 1 centimeter. Sternal punctures are best avoided these days. It's not a procedure that's a very comfortable procedure, so we just generally don't do it. Okay, but once upon a time when we were training, this was the site for bone marrow aspiration, and we did get good material, but it was a scary procedure. All right. Aware that there are two techniques, the aspiration and the trephine. So let's look at the aspiration. When you do an aspiration and you put out the material, first thing we do is we try and drain out the blood. Now, this is in different situations, right? In some situations, suppose you're doing an aspirate in a case of leukemia, you must keep the aspirated material in EDTA, must take it in EDTA. But if you're doing it for other just morphological reasons, you can make straight smears. When you're making a smear straight, see that you drain out the blood and make a aspirate smear. There are two ways of doing it. I hope you're aware of. Whatever you're comfortable with, like a wedge or like a squash smear. One important thing is do not apply too much pressure. Do not apply too much pressure into doing the smearing, because you're likely to crush and the cells are very fragile. So that's important. Why isn't it moving? Yeah. So when you get a good aspirate, it's quite nice. There's a particle and you are full of cells. So you are quite happy with it and you can do a lot of studies on it, right? So tests that might be required in a bone marrow are routine and selective. So what do we do routinely?
CBC.
One sec. Why isn't it moving? Yeah. Routinely, what do? We do Romanowski stain most of the time, cytological assessment, Leishman or Jeamsa, whatever you are familiar with. When I was in JIPMER, we had done a little study on a Leishman-Jeamsa cocktail. You can Google it up and look at it. This kind of reduced the turnaround time. We could stain it fast. It was ready. Marrow staining was ready within 30 minutes. So this is one way we can improve. And for most aspirates, routinely we do a pearl stain when we are assessing the iron stores. Okay, if it's a good particulate, you always put up a pearl stain. The incidence of iron deficiency is so great that if you do a pearl stain, you'll be able to talk about the iron stores irrespective of the diagnosis. You'll find that most of it is grade 0. Okay, selectively depending on the case, cytochemistry can be done, immunocytochemistry can be done, immunophenotyping can be done, karyotyping, molecular studies, and culture. Okay, so these are selective. So this is how we do the tests. So the bone marrow aspiration is technically easier, quicker turnaround time, and hence is popular. Mind you, though it is technically easier, it is more painful. The fact that aspiration time, if you have done it routinely, you would realize the amount of pain that you cause, no matter how well anesthetized the patient is quite phenomenal. But it's a popular, quick, we can report it within 2-3 hours of doing the aspirate, do a good stain and report it out. We have this 59-year male, backache with severe anemia, hemoglobin 6.5, TLC 3,600, platelets 30,000. Yeah, Sabha, can you just look at the smear and tell me what are the changes that you're seeing?
Some microcytic hypercomic morphology of the RBC. And sir, I think base of it.
What the arrow is showing to? What do we see?
Teardrop cells also.
Very good. Teardrop cells. What do you think this cell is? Or this cell is? Okay, teardrop cells. Anything else you want to comment on this cell? Nucleated RBCs. Good. Yes, NRBCs. So overall, you see a pancytopenic picture, platelets not so high. So this kind of a picture is known as?
Microcytic hypercomic.
Oh no, once you've got teardrop cells, once you've got NRBCs, low counts, I would keep it as a leukoerythroplastic blood picture. Whether it's microcytic hyperchromic, that's a different issue altogether. So this is what I was talking about, morphologic abnormality on the peripheral smear, right? So now I know that this patient has got pancytopenia. One indication, remember the first one, unexplained cytopenias. Second indication is morphological abnormality on the smear. So this is one case where I would like to do the marrow. Okay, if it were just an iron deficiency, microcytic hypochromic, I need not think of doing a marrow. Okay, understood?
Yes, sir.
Yeah. So when you're reporting out on a smear, report out on something that is more critical than the other first. Okay, right, fine. So what do? We do a marrow, and this is what we get in the marrow. Overall, if you look at the cellularity, it's not too good. So can you just tell me some of the cells? What is this cell I'm pointing to right in the center?
Some
Looks like a
Myelocyte.
I'll think of it as a blast. I'll think of it as a blast. It's
Okay.
too much of a vesicular, prominent nucleolus, hardly any granules. That's good. Those who have said the blast, perfect. What are these cells? This.
Nucleated RBCs.
These ones. Who will do? Anushila? Yes, they're all erythroid. No, these are not myeloid. These are all erythroid cells. You see a late novoblast, you see an intermediate novoblast, you see an early novoblast. Few collections of a few things. And if this is what you see in the whole smear, it is not a good smear. Okay, you can report out that you see a few myeloid cells, you see a few erythroid cells. I don't see a megakaryocyte. And if this is the entire picture, I would not be very happy with this aspirate. And what would I like to call this aspirate? It's kind of a dry tap. It's not a very cellular aspirate. It's not giving me much information. There are no particles, hardly any cells. So now can you tell me what are the causes of a dry tap?
Fibrosis.
Fibrosis, excellent. Anyone else?
MPN.
Beg your pardon?
Sir, MPN.
I'm not asking for diagnosis. I'm asking for conditions where you would get a dry tap. One is fibrosis. Yes, perfect. Hairy cell and all are all right. So let's look at the pathogenesis. So there has to be fibrosis in the marrow to give us a dry tap. Packed marrow, excellent. AR, whoever you are. When the marrow is packed, though uncommon, you may not pick up a good aspirate because the negative pressure may not work out very well. Yeah, any other? So far, I'm just listing on fibrosis and packed marrow. Anything else that is more common many a time, especially when you are beginning to do a marrow?
It's a faulty technique.
Technical, right? You may not be in the marrow at all. You may not have reached the marrow. Okay, it's quite often in obese patients. You may not reach, your needle is too short. Okay, you're doing an aspiration. That also is very, very important. Or you are just in the bone. You have not penetrated the bone, right? Okay, so generally, these are the causes where you get a packed marrow. Technical, no marrow elements, that is fibrosis and necrosis. A cellular marrow, packed, which is poor aspiration, or your pathology is in the bone, osteosclerosis is there. You know, many a times in multiple myeloma, you may not get a good aspirate because the bone is so hemorrhagic, the bone is so brittle that there is a lot of hemorrhage. We'll come to that in a little while. Now, many of you wrote aplastic anemia, but I have not put that as a cause of dry tap. Want to argue? Anyone wants to argue with me? That why haven't I put up aplasia as a cause of dry tap? By definition, dry tap is when you do not get material. Okay, they don't say. So what happens in aplastic anemia? You get lots of material. We'll see cases. You do get very hypocellular particles. You get fat. So it is not technically speaking a dry tap. It is a hypocellular marrow. You don't have cells, which makes the reporting difficult. But that's how an aplastic marrow is. Aplastic marrow doesn't have cells. So don't think of it that if you have a dry, actually, if you do an aspirate in an aplastic anemia, you should be getting hypocellular, you should be getting lots of particles. Fat is very easy to aspirate. Understand? It is a poorly cellular aspirate. It doesn't have cells because the marrow doesn't have cells to come out. Okay, so now we'll see certain situations. So if your marrow is aplastic, you get particles like this. Don't call it a dry tap. Call it a cellular particulate marrow with hypocellular fragments, hypocellularity, and reduction in the hematopoietic cells. We'll see some cases to understand. In contrast, if you have a fibrotic marrow, you are likely to get a true dry tap. Nothing will come out. Okay. Or if your pathology is in the bone, anyone can tell me what this disease is? Just a quick low power view. It's a marrow in a baby, about 2 years or 3 years old baby with pancytopenia. What anyone can tell me the diagnosis of this? A 2-year-old baby with pancytopenia. Anyone volunteering? Fibrous dysplasia. It is a bone marrow aspirate. Paget, Fanconi. Fanconi is aplastic. Fanconi would be this kind of a marrow. Anyone. Pagets and all are focal. It doesn't happen. Fibrous dysplasia of the bone, posterior superior iliac spine or the tibial tuberosities. That's a localized lesion. Storage disease. Notice we'll come to this. Okay, there's a lot of cartilage, very irregular cartilage, lot of bone in the marrow. CDA I cannot diagnose on low power, Chandrika. I need to see it under oil immersion. Okay, this is a condition called osteopetrosis, marble bone disease. This is the diagnostic blood marrow picture in low power, a trephine biopsy picture. Irregular spicules of bone all over the marrow and very irregular cartilage. We'll just come to this case in a while. Okay, now why is this condition, this slide? Anyone can tell me the diagnosis of this slide? I'll not give you any history, but looking at this bone marrow, what is the what do you think is the patient have? Any one of you, 5 of you, you can say it out or write. The people in the chat can write. Sakshi, Shaba, Anushila, Tahir, Ayon. VS. Can you specify it a bit? These are not granulomas. VS you did say CLL. Anything? Very good. It's a nodular infiltrate. Most probably this is a case of some lymphoma with a nodular infiltrate of the cells. Now, why is this kept as a dry tap? Or it's not really a dry tap. What happens in such situations where the lesion is focal? If you are doing an aspirate from here, can you see the pointer? If you are doing an aspirate from this area, you are likely to get a normal marrow, right? But the disease is over here. So such a situation may give you a false negative marrow. On the aspirate, if you're limiting yourself to an aspirate, you're likely to call this marrow as a normal marrow, where actually once you do the biopsy, you're going to pick up the disease. So all these are causes of failed aspirates. So what do you do when you have marrow is fibrotic, acellular, the lesion is focal, or it's a bony trabecular disease? You carry out a trephine biopsy. By and large, we do it simultaneously. Whether you do the aspirate first or the biopsy first, it's your own prerogative. But whatever I have done in all these, I prefer to do the biopsy first, because whatever you do, there is a lot of hemorrhage that one procedure does. So we do a biopsy followed by an aspirate. That's there because the hemorrhage in an aspirate is much, much more than the biopsy. But whatever you do, an aspirate or a biopsy, it's important to do the procedure 1.5 to 2 centimeters away from the entry point of the bone. So you've done the biopsy. See to it that when you're putting in the needle for the aspirate, it is not in the same entry point. At least you've anesthetized a good area. So go at least about a centimeter or more and insert the needle, penetrate the needle into the bone at a slightly far away from each other, and try and use separate needles for both. That minimizes the hemorrhage. So whatever you do first, be sure you follow this step. The entry point of the aspirate and the trephine should not be the same, because that is the path where hemorrhage has occurred. So these are the various needles. You know of the Salas, the Klima, that's the Jamshidi, that's a Westermann Jensen on which I did my training, and now disposable needles are all available. Okay. It's good to do an imprint. When the people earlier, if an aspirate fails, do an imprint, it doesn't. Whether you have an aspirate good or bad, make an imprint. So you have basically 3 types of samples: the aspirate, the bone marrow imprint, and the trephine biopsy. And all these 3 act in concert to give you a diagnosis. A trephine is almost imprint is almost a trailer of a trephine, and often the yield is as good as an aspirate, if not better. Okay, most of our immunocytochemistry, when we have to do it, it's better done on the imprint than on the aspirate. That's my experience. Aspirate causes a lot of hemorrhage. There's a lot of blood mixture. So immunocytochemistry, understand? Use of antibodies on the smear, immunocytochemistry, is better on an imprint than on an aspirate. At times, your biopsy clots, use that as a routine sample. You get a lot of material with it. Don't throw away the clot. Processing, few words, it has to have a fixative. It could be, most of the time, the best fixative is 10% Broford formalin. For the last 10 years or so, we are using AZF, acetic acid, zinc, and formalin. Notice that this, for 24 hours, this fixative has not just the fixative formalin, it also has a weak decalcifying agent. So the bone marrow biopsy starts getting decalcified as it is getting fixed. Okay, this is a part of so-called the Hammersmith protocol. I'll just outline it in a while. Which situation do you use Zenker's fluid as a fixative? Not very common, but if you want to do something, you would use a Zenker's fixative. Anyone? Anyone volunteering? Zenker's fixative is used when you want to study the iron stores on a trephine biopsy. We generally don't do it. We rely on the iron in the aspirate on a trephine biopsy, but if there is a study that is going on or whatever you want to do research purposes, use Zenker's because iron gets leached in formalin processing. Okay, so that's it. Picric acid for biopsy. Yeah, you could use. But the best fixative is a formalin-based fixative. Picric acid has the staining issues of staining and all, so we generally don't use it. Followed by decalcification. Now, if you have used acetic acid in your 24 hours, you need not decalcify for more than 6 hours. Formic acid is a good fixative for 6 hours. So this process of AZF and stearin or formalin acid is called the Hammersmith protocol. And the turnaround time has reduced. EDTA is another excellent decalcifying agent. But the problem with EDTA is that it takes at least a minimum of 48 hours to decalcify. Okay, so remember this fixative, whatever your departmental policy is, use formalin. This process of Hammersmith, it's a good protocol to follow. It was there by Dr. Naresh some years back, and we have had very good results with this. You can do staining, immunochemistry, molecular, anything with this fixative. Okay, so now let us take up what all can be done with a bone marrow. Everything. Just like the Dashabhuja, the 10-headed goddess, you can do morphology, special stains, flow, immunos, karyotyping, FISH, molecular, PCR sequencing, and culture. But the most important thing is the clinical details, CBC, and peripheral smear. Never report a bone marrow without the knowledge of the CBC and the peripheral smear. Never report a trephine biopsy without knowing what the aspirate is. There are centers in the country and outside where aspirates are reported in hematology, trephine biopsy is reported in histopath section, and there is a big wall between the two sections. Never do that. Anyone senior here, ensure that all your available resources are kept in one place and reporting is done with concert with both the techniques together. So let's start at the very beginning. Clinical details important to know the CBC and peripheral blood and the retic count. Aspirate should be always available as they are complementary. So when you interpret a bone marrow aspiration, biopsy now, the length is important. Normally, there is a 25% shrinkage during the processing. So you should, when you're doing a biopsy, aim for at least a 1.5 to 2 centimeter long biopsy. Okay, that's important. Should have at least 5 to 6 good trabecular spaces. Adequacy, actually, people many times ask, what is an adequate bone marrow biopsy? It depends on the case. If you have a tiny little biopsy, less than 1 centimeter, 0.5 centimeter, but you find a granuloma in the first marrow space itself, that's good enough for you. Okay, so when we talk of adequacy for any sample, it is to say that this biopsy is not diseased. This biopsy is normal. That's when you need at least 5 to 6 marrow spaces so that you can say with confidence that what I am looking is normal. There is no obvious disease in this. So understand. So we say that a biopsy, for whichever, is adequate so that we are comfortable about the fact that this biopsy, I can report it out as within normal limits. That's the reason why we need to know an adequate. Understood. If you have the disease pathology in the first or the second trabecular space, you can go ahead and diagnose your condition. So this is a nice long adequate biopsy. How do we assess the cellularity of a marrow? That's the next very important question for the beginners. Cellularity of the marrow. Now I'm giving you three pictures. What is the first question you will ask me when I'm asking you to assess the cellularity? Anyone?
Age.
Very good. I need to know the age of the patient. So generally speaking, roughly, it's said that 100 minus age is the cellularity. It's okay, but generally remember that in an adult, from the age of maybe 30 to 60 or 70, it's about 50%. Okay, so that 100 minus age is a rough guide, not true. So this, in a child, when it has so many fat spaces, is obviously a hypercellular marrow. But the same marrow in a 80-year-old man is normal for age. Understand? So cellularity depends on the rough ratio of the cells which are seen in blue to the fat spaces, but you must know the age. So this kind of a marrow, this marrow is definitely hypercellular. Right? Whatever be the age, even if it's a newborn, I'm not seeing a single fat space. I would take this as a hypercellular marrow. This is a normal cellular marrow for an adult. Okay. The same marrow becomes hypercellular if it is a 90-year-old or an 80-year-old man. Right? So I hope you have understood that. In general, when you're looking at a refined biopsy, this is how we look at the cellularity. Okay. This is usually the cellularity of a child. This is of an adult, and this is of an elderly. Okay, got it, all of you?
Yes.
Something I want you to notice in this, that whatever be the age, there is a fat space near the bony trabeculae always. Even in this child, even if it's a 1-year-old child or a small, there is some amount of fat there in the marrow. Okay, now this fat space in the paratrabecular location, just next to the marrow, is called the first fat space. And that's important when we are assessing the marrow. This is normal. When the marrow becomes cellular, starts getting to be cellular, start getting to be more proliferating, the first fat space is the first space that gets obliterated. Okay, the proliferation starts from the paratrabecular area, whatever it be. Okay, so remember this. Presence of the first fat space indicates that the marrow is generally good cellular. It's a normocellular marrow. Loss of fat space. Now this one, suppose it's this is a marrow of, let's say, a 40-year-old man. But if this is the marrow of a 40-year-old man, you see that the fat space has started getting diminishing. So this is getting to be a hypercellular marrow. And this, therefore, is a truly hypercellular marrow. So when you are assessing the cellularity, keep a note on the first fat space. Another important aspect of the cellularity is this concept of subcortical hypocellularity. Whatever be the age, it is normal for the first two spaces in the cortex. That's the cortical, that's the periosteum, that's the cortical bone. Subcortical, whatever be the age, is always hypocellular compared to the rest of the marrow. This particular bone marrow is very nice to understand this concept. It's a normal marrow. But suppose your biopsy was small. Suppose your biopsy was small and was limited to this, you may be tempted to call it a hypocellular marrow. That is why you need an adequate length to say that the marrow is normal. Okay, if you had what I was trying to refer right at the time, have you understood now? Understood? If you had a 0.5 centimeter marrow, don't call it a normal marrow. Don't call it a hypocellular marrow, unless you have seen at least 5 to 6 marrow spaces. Okay, but by chance, if you had a granuloma sitting over here, or a metastatic focus sitting over here, or a Hodgkin lymphoma RS cell sitting here, that would make it a diagnostic marrow. All right. So this is another higher magnification of another case. This is the hypocellular part in the subcortex, and I could not take it in one go because it's on a high part, and that's the rest of the marrow. It's a very cellular marrow. Okay, right. So when you are evaluating an aspirate and a biopsy, these are the points that we note down. So we talk about the particulate, whether it's particulate or not, and try and comment on the cellularity, though cellularity is best advocated on a refined biopsy, best understood. You look at the erythroid cells, myeloid cells, do an ME ratio, megakaryocytes, plasma cells, lymphocytes, macrophages, abnormal cells. Iron stain is done on an aspirate smear. Okay, we generally don't do iron on a refined biopsy. A biopsy is reported under these headings: adequacy, cellularity. Look at the hematopoiesis. Apart from morphology, you can talk of the topographic localization. We'll discuss where they are located in a little while. Look at the plasma cells, lymphocytes, macrophages. Fibrosis is always done on refined biopsy. You can look for infiltration, metastasis, lymphomas, granulomas, and certain other stromal changes are diagnostic on a biopsy. These changes like necrosis, serous atrophy are not very well reflected in an aspirate unless it's a very florid necrosis or florid serous atrophy. You can pick it up on an aspirate. So each of them have their own role to play when you're interpreting. So how many cells do we count in an aspirate?
So 500.
Okay. Do you really do 500? Again, here you have to, I'll be fine. All of you are doing 500. Okay. I am not so diligent. So I would do at least 200. Again, what is the case I am dealing with will make me do count the cells. Okay. Like suppose I have done a marrow for, let's say, hypersplenism, and I'm on a good look, I'm looking at it as a normal marrow, some amount of erythroid hyperplasia, etc. I will not bother too much about 500 cell. I will do a 200 cell, do a good ME ratio. Normal 2:5:1. That's the normal ME ratio, and be with it. But suppose I am looking at a case of an acute leuk or an MDS or a myeloma where I have to be more accurate, then I will do a 500 cell count. So a differential count should be performed in the trails behind the several fragments, depending on the indication. An ME ratio is often more than enough in cases of anemia, staging marrows, ITP, etc. Okay, I would do, as I said, acute leuk, MDS, myelomas, then I will see more cells, as many more cells as I can to do an accurate count. Got this picture? It doesn't mean that you ignore all the marrows, the normal marrows. No. Beginning of your career, when you are starting to identify, it's very important to look at as many cells as you can in a marrow to be able to identify what these cells are. Unless you do that, your whole interpretation goes for a 6. So familiarize with yourselves with the cells, with all the different types of cells. Look at as many cells as you want. But if it is kind of a normal marrow, just maybe a hypercellular marrow, where the exact values don't matter, the exact counts don't really matter, you could do a 200 cell count and do an ME ratio. But in situations like, you understand, where that you need to count the blasts, you need to count the plasma cells. In that situation, do a more detailed count. There, you need not even bother too much about the ME ratio. But there you'll have to talk about the cells. And therefore, again, it's smart playing, it's strategic. In which case, I need to do what I need to do. That's important, and that is something you have to learn. So if you have a marrow like this, a very cellular marrow, and now familiarize yourself. I mean, of course, in these half an hour, you won't be able to do that, but I hope all of you have seen marrows. So a well-stained, good aspirate gives you all the material that you need to assess the cellularity. Okay, so there's a megakaryocyte, there are myeloid cells, neutrophils, erythroid cells. That's good. Same thing you can appreciate on a refined biopsy. If your refined biopsy is thin and well-stained, you can identify all possible cells that you see on the aspirate on a refined biopsy. Notice there's a megakaryocyte here. We'll go into the details of these cells in a little while. Okay, a good refined biopsy, though this is hemorrhagic, it's a thin biopsy and you can identify all possible cells. Okay, so pick up marrows and try and identify all the cells for those who are beginning. Okay, any answer to this? Anyone? If you have heard some of my previous talks, you would know this is a kind of a joke. Anyone knows what happened to the RBCs, WBCs, and platelets? Well, they all had a marrow escape, right? Not let you escape for some more time. And let's move on to how the erythroid cells look. Okay, I'll not again go into too much of morphological details. You know that these are the early forms, the proerythroblast, early, intermediate, late. What happens in this hematopoiesis? Few things you must remember. Two major things. The size of the cell decreases. The nucleus becomes pycnotic and disappears. The nucleus gradually becomes shrunken and disappears. And hemoglobinization takes place. So when you're looking at an erythroid cell, identify it from this set. Hemoglobinization takes place at what stage?
So
At what stage?
Intermediate
Normoblast. So by the time it becomes an intermediate to a late, the cytoplasm color should match the RBC color. Okay. This should become the buff colored, the same color as the RBC in the late normoblasts. Okay, that's an important point. All right, we'll see cases again. On a refined biopsy, oh, this is an aspirate side. These are early forms, early normoblasts. This is how the colony of erythroid cells look. These are all aspirates. You know, I've just taken random pictures showing you the erythroid cells, and we will see some more in a little while. Okay, so this is where the erythroid cells are hanging around, and they're always in clusters. And you can, in a good aspirate, you can make out the stages. And they are often, yeah, we've done that, right? Okay, first question, which stage of erythroid cells is the most predominant?
So late erythroblast.
Actually, it is the intermediate erythroid cells. The intermediate normoblast or the intermediate erythroblast is the most abundant. When you are doing let's say, a differential count of the erythroid cells, you're counting 100 cells or 200 cells, the early forms are about 10%. The intermediate forms are about 40 to 50%, and the rest is late. So there is this kind of a peaking at the intermediate and then going down. In which condition does the reverse take place? That is, there are more of early forms and less of maturation. One important disease, common disease, where maturation is defective. Which disease? Megaloblastic anemia. Excellent, Sharik and Soumya. Very good. Megaloblastic. In which condition is it reversed? There are too many late forms. Which common condition? There are too many late forms. And anyone? Too many late forms are seen in iron deficiency anemia. What is the erythropoiesis called in iron deficiency? Micronomoblastic, right? So that's how you look at it. That's why it's important to look at it. We generally don't do a differential count of the early, intermediate, late, but eyeballing, just overall get an idea of roughly how many early forms, how many intermediate forms, and how many late forms are there. Okay, what is this? That's an erythron. Often you will find this erythroid cells surrounding a macrophage. These are the nursing cells. This is what is actually happening, how iron is being taken in from the macrophage. What is this called? This phenomenon is known as? Anyone? It's an erythron, it's an erythroid cluster, but this says, how is it? It's called, no, this is not emperipolysis. This is not emperipolysis. The erythroid cells are not inside the macrophage, they're surrounding it. This process is called rhophocytosis. Rhophocytosis, yes, it's an erythron. And the process by which the iron is transferred is known as rhophocytosis. rhopheocytosis. Rhophocytosis. Okay. So this is an aspirate, and that's the trephine. So again, notice a good section will give you the diagnosis. These are all the erythroid cells. One thing about an erythroid cell colony in a trephine biopsy is this retraction. The empty space around the cells. They're in clusters. Notice there's an early form, and these are all the late normoblasts. It's kind of retracted, empty space, fried egg. And this is how an erythroid colony is identified on a trephine biopsy. At times, you might mistake it for a lymphoid cell. Okay, so beginners keep a track of that. This one, same thing, clusters of late normoblasts. Okay, this is obviously erythroid hyperplasia, and most of them are immature, the late ones, the more mature ones. So this is what you see in an erythroid hyperplasia and erythropoiesis. These are the early forms. At times, you will find early forms. It's in the interstitium. And here, what is your differential diagnosis? You are worried about whether they are myeloblasts, alib, or blasts, other atypical cells, and erythroid. Again, notice they are in clusters. They are in clusters. And this is what you get in, yeah, you might get it in M6, but this is a common finding in simple megaloblastic anemia. The early erythroid cells in megaloblastic anemia, the early proerythroblast and erythroblasts have one little soft point. Their nucleus is not necessarily round, slightly linear. Okay, this is the typical appearance of an erythroblast, the linearity of the nucleus. And often it is at the periphery, often if it is at the kind of not in the center, and they are often hazardous linearity that is there. Okay, we'll see these again in a later. So this is the doubt that we have. So at times you need to do certain immunohistochemistry to identify. Suppose you've got a post-chemotherapy marrow. You're not very sure whether these are the erythroid colonies or these are the original blasts or these are the regenerating blasts. You might need to do certain immunohistochemistry. A good immunohistochemical marker that we have found very useful in early forms, megaloblastic anemia, MDS, etc., is the cadherin. Epithelial cadherin, it's elicited by the erythroid cells in the cytoplasm, CD71, anti-carbonic anhydrase. As the cell matures, the E-cadherin becomes less prominent. CD71 is well retained in the intermediate forms. But notice the commonly used marker for erythroid lineage in a flow cytometry is glycophorin A. That comes only later on in the maturation. When it becomes a late normoblast and RBCs, glycophorin A takes over. The problem with glycophorin A in his immunohistochemical appreciation is that RBCs are also stained by glycophorin. So because a bone marrow biopsy has a lot of RBCs, often interpreting an erythroid lineage on glycophorin A in a trephine biopsy is difficult. So, and generally speaking, we need to look at immunohistochemistry in the early forms, right? Megaloblastic, PRCA, when you have to identify early forms, MDS, there E-cadherin is a very good marker that is in our experience. CD71, anti-carbonic anhydrase are also equally good in literature. So others may have those. So now this is a normal early form. What is this? On an aspirate. That's megaloblastic, right? Sieve-like chromatin, prominent nucleolus. And that's a normal late normoblast. And what is this? What are these? That's normal early intermediate forms, and that's a megaloblasts. And what are these? These are late normoblasts, but notice that the cytoplasm isn't as the color of the RBCs. There is still bluishness of the cytoplasm. This phenomenon, and also notice that the cytoplasm is kind of vacuolated. This phenomenon is what is seen in micronormoblastic erythropoiesis, particularly in iron deficiency anemia. Of course, vacuolated normoblasts can be seen in thalassemias, can be seen in copper poisoning, but generally, this is the late normoblast that's normal. This is a late normoblast, which is iron deficient. Notice the basophilia. We use the word persistent basophilia in the late normoblast when we are referring to iron deficient erythropoiesis. Understood? So that's how a late micronormoblast looks. An iron deficient normoblast looks. Vacuolation and persistence of the blue color. And this is a late normoblast because it's got a pycnotic nucleus. Absolutely. Okay, it's not an intermediate or a late normoblast. Got it? Certain other changes, binucleation, trinucleation. In which condition? CDA. It's a reactive process. You might find a few binucleated and trinucleated cells normally also, some defective RBCs. But if you see predominance of this, think of a congenital dyserythroid anemia. That's a Cabot ring, figure of 8, and these are Howell-Jolly bodies. So these are some of the changes that in the erythroid cells you can pick up. Myelopoiesis is always paratrabecular. It starts in the paratrabecular region. Normally, you cannot find a blast in a normal marrow. Difficult unless you put up some immunostaining. The blasts are not used. They're so few in number. So in the paratrabecular area, but you can appreciate the myelopoiesis going on. The maturation of the neutrophils towards the center of the marrow. And these are some of the early forms of the marrow. And I'm not again going, I hope all of you are familiar with the morphology of the blast, promyelocyte, myelocyte, meta, band and a neutrophil. This is what a trephine looks at the edge. You might pick up a few early forms unless there is, and notice the maturation as it is going. Some band forms here, neutrophils, and the center of the marrow is full of neutrophils. That's normal hematopoiesis. I was talking of topography. This is what it is. So erythroid cells are in the interstitium, intertrabecular area. Myelopoiesis starts from the paratrabecular and gets into it. So you do not find abnormal or immature cells in the center of the marrow. Aspirate beautifully, we can see all the cell lines. Similarly, a trephine biopsy well made can be seen, all cell lines can be identified. In case you have a doubt and you want to assess really how the hematopoiesis is taking place, do a myeloperoxidase stain and they are positive. We can do a CD34, but normally CD34 doesn't highlight the blasts because there are so few in number. We do a CD34 when we are thinking of some myeloid dyspoiesis, topographic alteration. I'll just show you the slides. So that's how you get myelopoiesis. Notice the mature ones are very strong. These are the neutrophils, and the immature ones are less strong. And that's how it shows the maturation of myelopoiesis. What is this stain? What I say is this. Identify this. No, this is an immunohistochemistry stain. So this has highlighted something that has highlighted the endothelium and also the immature cell. So which cell, which stain should this be? It has highlighted the sinuses. Yes, good VS. This is CD34. It has highlighted the sinuses as well as in one immature cell with a prominent nucleolus, another one. So this is a CD34. And generally, as I said, in a CD34, in a normal marrow, you will not pick up too many CD34. Some stem cells here and there, you can pick it up. Yes, Rimjim, binucleation of normoblasts can be seen in MDS, but there you will find other features, and they are usually megaloblastic, MDS erythroid cells, right? Okay, now coming to this picture, you have this little cluster of cells, like immature cells. This is one where I will apply CD34. Or I will apply maybe an E-cadherin if I want to understand what these cells are. Okay, normal CD34 in a normal marrow is hardly ever appreciable. Okay, so what is this cluster? To stain immature myeloid cells, and here I am getting a CD34 cluster. This is distinctly abnormal. And what is this called? This phenomenon of immature cells in the interstitium, not in the paratrabecular area, is called ALIP. Full form, abnormal localization of immature precursor. Another feature that you see in MDS. Okay. Understood. CD34 we apply when we are suspecting increase in the immature cells. Normally, you may not be able to pick it up. Megakaryocytes are easy cells to identify, but they can create a lot of problem. They are large. They are multi-lobated. They are not multinuclear. They have an abundant cytoplasmic granular cytoplasm with platelets sticking out. When you look at a megakaryocyte like this in your marrow, you know that megakaryopoiesis is active in this marrow. Okay, and this variation in size, shape, nuclear molding is all normal. Okay, so this tells you that this is a functional megakaryocyte because it has got granules, and you can see little platelets sticking out, right? Again, a nice functional active megakaryocyte. The granularity of the cytoplasm gives you a clue to its activity. This variation of size, shape, nuclear content is normal. I hope you understand why, because the megakaryocytes are such a big cell. They're the biggest cell in the marrow, 30, 40 microns. And at the section where it is cut depends on its morphology. So if you see this, right, if you see this football like as big as a football, okay, in a field, okay, very good. Rest of them are ping pongs, your tennis balls, and the megakaryocyte is like a football. Good analogy. Excellent. They have this variation. Now, if you see this variation in size, some of them may look actually very dysplastic, monolobe megakaryocyte, small one. But when you're seeing it in accompanying normal looking megakaryocytes, that's normal. If all your megakaryocytes were like this, then is what I am worried about. Okay, so look for this heterogeneity. Look for this heterogeneity of megakaryocyte. That's how it should be. Any idea what this is? This cell? Two things from this picture you can pick up, which are important as far as megakaryocytes are concerned. Anyone can identify two important features on this field that tells us everything about a megakaryocyte. Okay, Jivantika is saying micro, hypolobed. Anyone? Hematogon, pon ball. Oh, no, none of you are right. No, none of. Where is the pon ball? Pon ball means multi. This is a single nucleus, right? Where is the lobation in this? It's one big blue blob, monolobated. Are you seeing the cytoplasm? Soumya, is that you, my resident? Soumya, fine. Are you seeing the cytoplasm in this? Okay, stop. Let us talk of the location of the megakaryocyte. Any of my 5 students, where is it located? Where is it located? Notice the sinus. Notice the RBCs. This is the characteristic place where a megakaryocyte should be. It is always in the cytoplasm, in the parasinusoid or perisinus. That's where the platelets are released, not trabecular, sinusoidal. It's in the sinuses. That's where the megakaryocytes are present. And that's how platelets come out of the megakaryocytes, right? How do platelets form from the megakaryocyte? The cytoplasm squeezes into the sinuses and they are budding out. Now, what has happened to this? One of you did say an exhausted megakaryocyte. This is a bare megakaryocyte nucleus. It has lost all its cytoplasm. All the patients, all the platelets have come out of this cytoplasm, and all that is left is a bare nucleus. That's normal. Okay, so this is giving you the entire function of a megakaryocyte. This poor old man is left with no kids. And it's all just the nucleus, and it is sitting next to the sinus. All of these megakaryocytes generally find them next to a sinus. Okay, what about these megakaryocytes? These are also megakaryocytes. These are more immature forms. They are called the pro-megakaryocytes. And in which condition do you see them? Most of them are very round, may not always show platelet budding, blue cytoplasm, and round. In which condition do you see a constellation, large number of such platelets? Such megakaryocytes. Immature megakaryocytes in clusters. Yeah, Sabha? Yes, Moment, you're right. This is what you see in ITP. Immature megakaryocytes. I will show you ET and all in a little while. This is what is called immature megakaryocytes, pro-megakaryocytes, and you often find them in simple ITP, megakaryocytic hyperplasia. The early forms are forming out. What is this? This phenomenon is emperipoiesis, a neutrophil traversing through the megakaryocyte. Okay. And what is this?
Encytosis.
That was emperipoiesis. What is this?
So encytosis. Encytosis.
What does that mean? It's endomitosis.
Yes.
Okay. The megakaryocyte does not really undergo mitosis and divide into 2 cells. They are forming, the nucleus is undergoing mitosis within the cell itself. Okay. It's breaking up and maturing within the cell. Okay. Another thing about megakaryocytes, when you're looking at it, especially in atropine, look at its location. It is always not in the paratrabecular. It is always in the interstitium and perisinusoidal. Look at the megakaryocyte outside a cytoplasm. This is almost inside the sinuses. This much of 1 or 2 megakaryocytes together is acceptable. So generally they are scattered, perisinusoidal in location. And notice again the kind of heterogeneous morphology. That's normal. But if you find them clustered, that's abnormal. Tight cluster without the presence of an hematopoietic cell within them. Paratrabecular clustering. These are all grossly abnormal megakaryopoiesis going on. The topography is changing. Right. All this you can get in myeloproliferative neoplasms. You can get it in MDS, etc. Clustering is abnormal. At times they can be very large, hyper segmented. Okay, and this is what you get in myeloproliferative neoplasm, especially in polycythemia. You can get it in ET, etc. These are all hyperchromatic, dark staining. And here notice, though they look variable, but they are all, more or less, all of them are large. All of them are hypersegmented. There is a clustering going on. There is a background fibrosis you can appreciate. So this is abnormal. This is abnormal. What about this? Dwarf, but monolobe megakaryocyte. Small-sized monolobe micro megakaryocyte. What you see in 5q minus. A small-sized but lobed. This is dwarf megakaryocyte, what you see in CML. Okay, so these are abnormal. These are all abnormal. That's a dwarf, that's a monolobe. Okay, so keep that in mind. If you need to stain the megakaryocytes, CD61 is good, von Willebrand factor anti is good, and this was one CD61 in an M7. Okay. Other cells, plasma cells, easily picked up on an aspirate. Trephine also, a thin section can help you identify the plasma cells. Often you get plasma cells around the sinus in an aspirate. Beautifully seen. That's where again they are located. Most plasma cells. Same thing in a trephine biopsy. That's the sinus. Notice the RBCs and plasma cells. In case you want to highlight plasma cells, you can do, what is this marker?
CD38.
38. Anyone else wants to argue?
138 also.
Right. Now argue between yourselves, two of you. Who said 38 and one who said 138? Which one? Okay, boss, baby, why 138? Okay, 138. Why are we leaning towards 138 and not 38? 38 is a very useful marker, but it is usually seen in immature plasma cells. It's also seen in hematopoietic malignancy, AML. It's an early marker. It's an immature marker. So if you are wanting to highlight plasma cells in a myeloma, etc., do a 138. 38 may confuse you when you do it as an immunohistochemistry. 138 is a beautiful marker for mature plasma cells, not the immature, very, very early forms of myeloma cells. That can confuse if you use 38. Okay, there are reactive forms. That's a flame cell. That's a Mott cell full of immunoglobulins. These are Russell bodies, binucleation. Here and there, a binucleation is acceptable. All these are reactive changes. Okay, that's what is this? Dutcher bodies. That's a Dutcher body, a nuclear inclusion. Okay, all these are reactive changes, but Dutcher bodies can be seen in which condition? Any abnormal, any plasma cell dyscrasia where Dutcher bodies are prominent. You might, but if you see a case full of Dutcher bodies, it's Waldenstrom. Waldenstrom where Dutcher bodies are important. Okay. Yeah, non-secretory may show Dutcher, but they usually show Russell bodies. Dutcher body is usually reserved for a bit more atypical myeloma cells, and that is Waldenstrom. Okay. What are these? Plasma cells. What are these? Anyone? Yeah, Sabha, you want to say something?
Plasmablast.
That's a plasma osteoblast. Excellent. These are osteoblasts. They are not plasmablasts. I'll just show you a plasmablast in a while. These are plasma cells. Notice an osteoblast has also a HOF, a perinuclear clearing, like a plasma cell. The nucleus is peripheral, like a plasma cell, but an osteoblast nucleus tends to push out, tends to go out, and is roughly triangular. So what does it resemble? Some name we give? A shuttlecock appearance, like a shuttlecock when you're playing badminton. Shuttlecock appearance is an osteoblast. Okay. And what are these? Osteoclasts. And you might confuse it with a megakaryocyte. Osteoclasts are multinucleated, but they also have granular eosinophilic, at basophilic generally, but you might find eosinophilic granules in them. May confuse. So this is one picture, beautiful picture that I've got where it shows osteoclasts as well as osteoblasts. It's a child with osteopetrosis. This was the things. Okay. Lymphocytes. In a marrow can confuse a lymphocyte and an erythroid cell. Often to a beginner may look very similar. Lymphocytes, they're usually 15 to 25%, more in infants, usually scattered, maybe in clusters, and you need to differentiate it from a lymphoma infiltration. So lymphocytes, erythroid cells. Okay, may look similar. What is this? And what is this? The left panel is a erythroid cluster. Ayan, Tahir, are you following? Ayan
Yes,
and
sir.
Tahir, are you around?
Yes,
Yes,
sir.
sir.
Yeah, so that's an erythroid cell because you're seeing this clearing. What about these? That's a lymphoid cluster. Many a times when you see lymphoid clusters, loose clusters, you may have to rule out a lymphoma infiltration. You could do a CD20 and CD3. When you see two of them together like this is reactive. Okay, in a neoplastic, you will see either 3 or either 20, right? So that's erythroid and that's lymphoid. Many a times this lymphoid clustering, you may have to differentiate from a lymphoma versus a reactive cluster. A reactive cluster is usually not tight. Notice here, it's not a very tight aggregate. A tight aggregate, remember the one slide I showed you before of a lymphoma infiltration when we were discussing the adequacy and the failed aspirate? They are often very compact. They are often, a reactive one is not monotonous. Like a reactive cell, that will have a lot of morphological reactiveness. And if you are in a doubt, you do these two stains. 20 and 3 are generally positive in a reactive situation. What is this cell? These are mast cells. In case you want to do, you can do a toluidine blue metachromatic stain to highlight them. They are often, apart from systemic mastocytosis and associated neoplasms, etc., often mast cells are very prominent in aplastic anemias, CLL, and the low-grade NHLs. You might see a lot of mast cells. What are these? Macrophages. That's a normal macrophage in a marrow. Proliferating marrows, ITP, thalassaemic marrows, hematopoietic lymph malignancies marrows, you might see a lot of macrophages. That is a erythroid cluster around a macrophage. You wanted to, okay, I'll just quickly go back. These are the mast cells, please. 1, 2, 3. That's a plasma cell. This one. They are often coarsely basophilic granules because of heparin. And notice this faint pink color. That's heparin that has leaked out of it, giving it a eosinophilic color. Okay, these are mast cells. Okay, what is this in relation to a macrophage? Anyone? That's a macrophage with lots of NRBCs. And there is a vacuole around each other. And that's hemophagocytosis. These are all the various types of storage cells that you can often pick up on an aspirate. An aspirate is better than a trephine biopsy for identifying storage cells. That's what you typically crumple tissue paper of Gaucher, fine vacuoles of Niemann-Pick, and the typical blue color of a sea blue histiocyte. Okay. What are these? LD bodies, right? Can be scattered, can be intracytoplasmic inside the macrophage. So that's also a parasite that you can pick up. As I said, Pearl stain, the gold standard for assessing iron stores, though we don't do it on a routine basis. To assess iron stores, we have ferritin and other levels. But if you have got a marrow for whatever be the reason, please do a Pearl stain that will tell you the stores. Prussian blue reaction, at least 7 particles. Here we need the adequacy. You need to see at least 7 particles before calling it grade 0. Okay, negative iron. It's graded from 0 to 6. 0 is deficient, 1 is reduced, 2 to 3 is normal, and 4 to 6 is increased. And that's how we grade. Absence of the blue color, 0. This is possibly 2, this is 3, this is 5 or 6. So up to this is reduced, this is normal, this is increased. Okay, we'll come to that case of emperipoiesis and hematopoiesis in a little while. What is this? Iron stain showing sideroblasts. Often go into the oil immersion to look for the sideroblasts. Otherwise, you can grade your iron in just low power or at the most a high power. You don't have to go into oil to grade. Grading is generally done in a low power. Okay, to say how much of iron is there. But if you want to look for sideroblasts, you must go under oil and identify them. and normal sideroblasts are there. They are present in the cytosol of the erythroid cells. They are ferritin sideroblasts. Pearl stain is done with a very few granules. Moment you see so many granules inside a normoblast, it's abnormal. And that's an abnormal. They are in the mitochondria. The normal ferritin is in the cytosol. But abnormal sideroblasts are iron loaded in the mitochondria. 5 coarse granules forming a ring around the nucleus, comprising at least 1/3 of the circumference. That's the definition of an abnormal sideroblast. Could be a ring or 5 coarse granules. It may form a ring, up to 1/3 at least should be covered, and that's abnormal. All these are abnormal sideroblasts. Which condition do you get sideroblasts? Other than sideroblastic anemia?
MDS.
MDS, good. We generally don't do pearl stain in a trephine biopsy because, as I said, the iron gets leached out and unquantifiable amount. How much of iron gets leached out, we do not know. So it's difficult to grade iron stores. If by chance you've got a iron trephine biopsy and you're finding pearl stain is positive, it indicates iron overload. Okay, normal iron cannot be identified on a pearl stain in a trephine biopsy because it gets leached out. So if it is still there in a trephine biopsy, means the iron is overloaded. We generally don't bother much about iron in a thing. As I said, in case you want to do studies, you can do as anchors. Fibrosis is what is graded on a trephine biopsy, and we follow the TL classification, WHO, and 2 stains are needed, reticulin and collagen. Grade 0, which is normal, scattered, linear, very thin fibers in and around, no intersections. That's grade 1. Loose, often perisinusoidal, perivascular. Coarse, extensive intersections, that's grade 2. It might show occasional collagen bundles. So when you see a reticulin like this, do a trichrome. In case you want to conserve, generally we do both together, reticulin and trichrome. But rationality says that unless you see grade 2 trichrome or grade 2 reticulin, there's no need to do a trichrome because it won't be there. So grade 2 reticulin, do a trichrome and look for the bluish collagen. Grade 2 also, grade 3 also indicates by osteosclerosis. So this is how you grade it: grade 0, grade 1, grade 2, and grade 3. Certain stromal changes like fibrosis, osteosclerosis, necrosis, serous atrophy are best appreciated on a trephine. So now let's look at quickly some very few cases where marrow is diagnostic. I'm sure you will be going ahead. 44-year-old male with pancytopenia. Anyone wants a breather or a question? Another 20 minutes or so, and we'll wind up. Okay, let's take this case up. And you see this. 44-year male. So you have a nice hypocellular fragment, right? Yeah. So what's your diagnosis, Tahir? That's the representative of the aspirate. That's the representative of the biopsy. Yeah. I was asking Tahir. Yeah, many of you are answering on the chat. Good. Perfect. All of you. Tahir, step in. Or anyone. Sakshi, Sabha, Anushila.
Plastic anemia.
Very good. Aplastic anemia. That's an aplastic anemia. And there could be other marrow failure syndromes, Fanconi, etc. Another patient, 45-year-old lady, also with pancytopenia. And that's the trephine biopsy. Hypo. But what are you looking at? Some cellular foci here and there, right? It's not as blatantly hypocellular as the previous one. You are getting some. Let's look at these foci in a bit thing. What are you noticing here? Who will do? Sabha? Let's not jump to a Jivantika. Let's not jump to a diagnosis. Look at the findings. Let the cells talk to you. You know, Dr. Borges used to beautifully describe it. Let them talk to you. Are these maturing? Is there any evidence of much of maturation? No. Yes, good. Jay, megaloblastic, good. I would think about it, but we did see megaloblasts that should have a linear nucleus.
Yes.
So when you are doing this, this is in the same marrow, which is overall hypocellular, but you have some, yes, good Mandeep. You have some immature looking cells in clusters. So I need to know whether it's leukemia or what it is. So what would I do? What stain would help me? Jivantika, you talked of a leukemia. CD32 or 34, you mean, right? Mandeep, 34. Right. Okay. I'll show you some more cells, some more areas. What do you say about these two megakaryocytes? Very round. This is what is a pawn ball megakaryocyte. Multiple lobes, pawn ball. I hope you are aware of what a pawn ball is. Yeah, that's beautiful. That's a pawn ball. So obviously, I'm seeing a cluster of immature cells. I'm also seeing dyspoietic megakaryocytes. So again, the same focus, I do a CD34 and I find out. So what is my diagnosis now? MDS.
Yes.
What type of MDS? Hypocellular MDS or AML, depending on the percentage of blasts, depending on the karyotyping. So what was aplastic anemia in one patient with very similar findings becomes an MDS, hypocellular MDS in the other. So pay attention to the cellular foci that you are seeing in a hypocellular marrow. 9-year-old boy with pallor, hemoglobin 5, retic of 0.2. That means he's got reticulocytopenia, right? More or less normal, excepting some anisocytosis. Nipple-shaped RBCs, looking like a nipple. Just keep this thing in mind. This is the bone marrow. What's the striking abnormality?
Erythroid hyperplasia can be seen.
Binucleation, right? Dyspoietic binucleation. Now, are you sure that there's too much of, look at the size of this cell. This is kind of a big late normoblast to be. Yeah. Two. You're seeing, what do you see here? A bridge between the two nuclei. So this is abnormal. This is not just iron deficient erythropoiesis. Another one. Look at this. Look at this. Look at this. So this is congenital dyserythropoietic anemia. Morphology has given you most of the diagnosis that it happens. A same history. Now it's a 9-month-old child. Pallor, hemoglobin 5, retic 0.2. Otherwise not significant. And this is the bone marrow. Aspirate. Lots of myeloid cells and some, hardly any erythroid I'm not finding. Instead, I'm finding these very large cells. Okay, so, again, Medha, not the diagnosis. Tell me the finding. Write down the finding, or anyone. What are these cells? Again, I don't want a diagnosis. I want the finding. One finding is that I'm only seeing myeloid cells. I'm not seeing erythroid cells. The normal ratio is about 2 to 3:1. I'm only seeing lots of myeloid cells. I'm not seeing erythroid cells. So that's my ME ratio is screwed up here. It's actually very high. And you have these what are called the giant pro-erythroblasts. There is a maturation arrest in the erythroid lineage. So these are pro-erythroblasts. These are not myeloid precursors. They have this dog-ear appearance. Good massa, intermediate, late not seen. Only early, and that too very early forms. And this is a diagnosis of pure red cell aplasia. Could be anything. Diamond black fun if it's a baby. It could be acquired parvovirus, antibodies to erythropoietin in a renal failure patient. It could be seen in thymoma, CLL, and other lymphoproliferative lesions, aplastic crisis in inherit. All these conditions will show you severe erythroid suppression. If it is parvovirus, you might find these dog ear or prominent inclusion like nucleolus. If it is not, all that you will see is this giant erythroblasts. 8-year-old male child, easy fever and easy fatigability, 1 month, no lymph nodes, counts low, peripheral blood shows 21% atypical cells. Okay, blasts, agreed?
Yes.
All of you? Yeah, great. Bone marrow shows 45% blasts. Right, agreed? So looking at it, what do you think?
Yeah, lymphoid cell count.
Lymphoid, excellent. So what will you do in this situation? What is the next investigation you will ask for? Ayan? Okay, Sakshi. Any of you, Sakshi, Sabha, Anushila, I'm not hearing you at all. Okay. Some of you want to do, yeah, come on, tell me who is speaking.
So we can go for flow cytometry.
Yes, you will go for flow cytometry. Yes, some of you may want to do a PAS or a dun black myeloperoxidase, fine. But in the current age, I need to know the immunophenotyping. That's where your bone marrow is a rich source for immunophenotyping. Okay, and you do an immunophenotyping. Let's not go into the details. Let's not look at it. This particular case turned out to be an MPAL, both B and myeloid, B and myeloid, MPO positive, CD34 positive, etc. So bone marrow is an important source for immunophenotyping. There is no doubt about it. That is the basis of classification of all your acute leukes, CLPD, etc. If your blast percentage is high on a peripheral blood, you might use a peripheral blood immunophenotyping. It will help you get a report, but generally the bone marrow is the source for immunophenotyping, especially when your blast percentage is low in the peripheral blood, as in subleukemic or aleukemic, or always in your post-therapy marrows for MRD assessment. 58-year-old lady with pallor, hemoglobin 5, and this is what you see. MCB is raised. The same case I've shown you before, dyspoetic MEGS. Right? Right. So what investigation would you do? Here in this case, previous one you did immunophenotyping. Here, what is your primary investigation? Cytogenetics. Excellent, Medha. Very good. I would do a karyotyping at the start of it. JAK2, I'm not too keen on this case right now. I need to do, because I'm discussing 5q minus or MDS, micro megakaryocytes, small size megakaryocytes, monolobe megakaryocytes, elderly lady, no spleen. So I would be interested in, before even molecular, I would want to do a plain karyotyping. This was the biopsy of that patient. Notice the clustering and extremely hypolobe MEGs. Extremely hypolobe, monolobe, not hypolobe, monolobe megakaryocytes, small in size, distinctly small, round cells. Cytoplasm is clear margin. I do a CD61, I highlight all of them. Whatever it is, I need to do the karyotyping and arrive at my diagnosis. Thereafter, yes, I might want to do molecular studies, etc. But at this point of time, for my diagnosis, I will use karyotyping. Now, it's a 58-year male, similar age, elderly male, pancytopenia and a massive spleen. Again, what are you seeing? Anyone? RBCs?
NR, teardrop cells.
Very good. Teardrop cells. And what are these
Target
two cells?
cells.
Target, not so many. Once or two, yes. And what is this? And what is this?
NRBC.
NRBC. So this is again, Mandeep, very good. Leukoerythroblastic blood picture. Again, let's look at the our indications: abnormal peripheral blood, pancytopenia, and organomegaly. And this is what I get in the aspirate. Not a good aspirate, but MEGs are there. Very dyspoetic, hyperchromatic, hypersegmented megakaryocytes. I think I've shown this low power earlier. Extremely large, bizarre, hyperchromatic megakaryocytes in clusters. And notice here and there, I think I have, okay, this I don't have. Anyway, we'll see cases later on. Later on, I don't have all the pictures. This is what you call as a, you do a reticulin stain, do a collagen stain, and you call a myelofibrosis. That's how you arrive at a diagnosis. Here, I would like to now rule out and do a JAK2 mutation, calreticulin, CALR, MPL, etc. when I'm dealing with a myelofibrosis. I would also like to think of it if the case is, whether it's a CML that has progressed, so on and so forth. So that will be my line of investigation, depending on what the case is. Another elderly male, splenomegaly with pancytopenia, diagnosis.
Hairy cell leukemia.
Hairy cell. The 5 of you, please speak louder into the mic. I'm not able to, I don't know, for some reason, I'm not able to hear you so well. Hairy cells. Excellent. So what will you do? What do you expect the aspirate to be?
Packed, dry tap.
This is what is a dry tap, not because of its packing. It is a dry tap because of the fibrosis. And that's the typical appearance of a hairy cell leukemia. Aspirate is blank because notice the cells, atypical cells, lymphoid cells with a little clearing. There at this point of time, I want you to appreciate that how similar this so-called fried egg appearance is to the erythroid fried egg appearance. Okay, many a times hairy cell leukemia are interstitial. They do not fill up the whole marrow. They interstitially infiltrate between the normal hematopoietic cells, making your life miserable, whether they are erythroid or whether they are hairy cells. Both of them look very, very similar, excepting erythroid cells are often clustered. These insinuate between the cells. But this is the typical fried egg appearance. Notice this cell and this cell. This is a hairy cell, that's an erythroid cell. Okay, the dark pycnotic nucleus is that of the erythroid. The lighter, paler nucleus is that of the hairy cells. You do a reticulin, beautifully outlines the chicken wire appearance, okay, the fried egg appearance, and that's because it's reticulin fibrosis, which is surrounding individual or small groups of cells. Okay, so this is the typical appearance of hairy cell leukemia. Another point, note down, in hairy cell leukemia, you do not get collagenization. It's one of the causes where only reticulin fibrosis occurs. And you do a CD20 and follow it up with the investigations. Notice it's only interstitial. It's a few cells which are actually the hairy cells. The rest of these are all actually erythroid cells. Okay, so that's an indolent neoplasm. You know about it. A 45-year male, generalized fatigue, cervical lymph node, diagnosed as follicular lymphoma, and marrow was sent for staging. And that's the peripheral blood of the aspirate smear. Again, CLPD, small cells, but notice the cleaving. That's the morphological clue to a follicular lymphoma. And what kind of infiltration occurs in follicular lymphoma? Anyone? In the bone marrow, what is the pattern of infiltration of follicular lymphoma? Nodular and good, paratrabecular. Two features, nodular and mainly paratrabecular. Nodular is seen in CLL, nodular is seen in at times in marginal, but the paratrabecular localization is typical of follicular lymphoma. Notice one nodule here and paratrabecular localization. Notice this nodule. This is not a reactive nodule because you see the fat has got displaced. It's kind of forming a real solid nodule here. Some infiltration is here, but notice there is no fat inside. So this is neoplastic. A reactive follicle will not really displace the fat, etc. And this is the classic paratrabecular localization. Do a CD20 and you can make your diagnosis. Many times, especially when abdominal lymph nodes, follicular lymphoma, bone marrow is often the first site of diagnosis. Okay, classical 45-year-old male with bone pain, insidious onset, hemoglobin more or less 7, creat low, creat high, albumin low, and you see these lytic lesions. You know you're dealing with a myeloma.
Multiple.
Okay. Right. So again, often an easy diagnosis if the amount of plasma cells are too many. Notice you get binucleation. You can get it in reactive, but here also you get this in neoplastic. Notice most of these plasma cells do not have the paratrabecular Hoff. Okay, they're kind of immature, not really. They look like a mature plasma cells in birth. This is often what you get when you have sheets of plasma cells. But if you have fewer plasma cells, it's always good to do a CD138 to highlight. You know, smoldering myeloma versus early myeloma, often a CD138 is used to highlight it. A 5-year-old girl with a big spleen, sick-looking child, abdominal distension, pallor 2+, big spleen. Hemoglobin is very low, no atypical cells in the PS, more or less okay. And that's the bone marrow aspirate. Diagnosis, Gaucher disease. I've written it out. Okay, that's another big group of indications of doing a marrow. Suspected storage disorder. Many of the storage disorders present with neurological manifestations. Gaucher may not present with neurological, may just present with enlarging spleen. 30-year male with PUO, chronic kidney disease, hemodialysis for 6 months, fever on and off. Again, look here and try and say why a marrow is indicated. PUO, 2 months, febrile workup negative. So unexplained PUO and low counts, cytopenias. Bone marrow aspiration was kind of reactive, not much change, excepting a lot of toxic change, 6% plasma cells. And this is what you saw in the biopsy. What is it? Diagnosis? Oyon, yes, go ahead. Oyon, I can't hear you. Anyone else? Amyloid. Okay, granulomas. This I would think of as necrosis. and I would like to go a little higher magnification and check it out. And I can find an AFB. This is very unusual to get a acid-fast bacilli in a trephine biopsy, which has got decalcified. If you find an acid-fast bacillus in a trephine biopsy, means that the patient is really, really immunosuppressed. The bacillary load is very high. Okay, now again, one more point on this marrow, this field. If I had done my aspiration, I must have done the aspiration from this part. I had called it reactive. Everything is normal here. So this is the importance of doing a trephine biopsy, because you pick up focal lesions on trephine biopsy. This in higher magnification, to those of you who thought of, I have not shown you the pictures, typically caseated with a few epithelioid cells in the periphery. So this was a caseated kind of granulomatous inflammation. AFB was positive. Okay, so the patient's PUO was solved. It's a useful indication. Another man with fever. Now the fever is of lesser duration, mild splenomegaly, and again an indication, pancytopenia. So fever, unexplained, and pancytopenia. What are these cells? Plasma cells, right? Lots of plasma cells. Some reactive forms flaming here and there. And this is what is seen. Diagnosis? Yeah, Jivan, that was a flame cell. Now this one?
Hemophagocytosis.
Jivantika, Medha, look again. This is what is hemophagocytosis. Who asked me about HLH versus hemophagocytosis versus M. peripoiesis? Okay, M. peripoiesis is usually 1 or 2 cells, right? Here you see a macrophage with lots of cells. These are platelets. These are platelets. These are NRBCs. NRBCs, myeloid cells, lots of NRBCs. Okay, so this, all types of cells, usually when it is in cluster and when there is this space or halo around them, this is usually hemophagocytosis. M. peripoiesis, so many cells will not, be able to fit into one histiocyte unless the histiocyte is abnormal. It's active. A normal M. peripoiesis occurs in normal histiocytes or normal megakaryocytes. Okay, so this, when you see it in profusion, when you see all kinds of marrow cells, it's hemophagocytosis. And this is what is the cause for pancytopenia. It's eating up all the cells. Okay, by the way, what happened to that dry tap that I had shown for that picture, elderly male with pancytopenia, leukoerythroblastic picture? That's, what is it, diagnosis?
Myelofibrosis.
Myelofibrosis, something else? Yes, this is adenocarcinoma, metastasis. Okay, with a severe desmoplastic reaction, severe fibrosis. So this is adenocarcinoma. I'll go ahead and investigate further. This turned out to be a prostatic carcinoma, which had infiltrated the marrow. Okay. Yeah, there was some question about, again, still some doubts about hemophagocytosis. We'll just come to it. So just now summing up, is everything so good and easy? Some pitfalls are there, obviously. It's not that. That's a big pitfall. Hemorrhagic biopsies. When especially I have noticed it when you do an aspirate from the same point of entry followed by a biopsy. You get a hemorrhagic biopsy and this is of no use. Nothing can be reported on this. Or the length of the biopsy, same thing. Nice long biopsy, the granulomas are here. If you were to limit yourself to this portion, you would not get a diagnosis. So that's the second important pitfall that we have. That's why we need a long biopsy. This one, that's near normal. This part of the marrow is all abnormal. There's osteosclerosis going on. But notice if your aspirate was from here, or if your biopsy was only this much, you would not be diagnosing it well. So good 2 centimeters is a good. More than that, you generally cannot take. So 2 centimeters is a good length. So whenever you have an aspirate where you think that the biopsy is going to give us some more information, always add this note. Kindly await refined biopsy report and try and report as early as you can. If you follow the Hammersmith protocol, you can report a refined biopsy within 48 hours. Generally 48 hours in case, but generally we take about 3 to 4 working days. But in case of emergency, make a note, train your technicians, get it done as fast as possible. So unsatisfactory biopsies, in our experience, about 5 to 6%. Most of the time it's because of size or a tangential biopsy along the iliac crest. I told you how to point your needle correctly. In a pediatric, especially in infants or neonates, often you get just cartilage. So that's a problem that you can have. And this is something that we do. Whoever is doing the biopsy, be gentle with the biopsy. Don't hold it or don't pick it up with a sharp forceps. Preferably use your fingers, gloved fingers, to transfer it from the petri dish to the vial, whatever. And if you have to use a forceps, be gentle with it. Don't crush it. Moment you crush it, your morphology goes for a 6. And over decalcification and under decalcification are also problematic. Many of our antigens, especially things like CD30,